So I'm actually incredibly pleased to introduce Dr. Brandt Van Sickle. It's a pleasure always to see a friendly face from the past. So Dr. Van Sickle was a fellow while I was at Vanderbilt. He double dipped at Vanderbilt and did both his pediatric residency as well as his fellowship. He has both an MD and a PhD. After finishing up in Tennessee at Vanderbilt, he moved back to the Midwest from where he's from and has been practicing at Akron Children's Hospital in pediatric endocrinology since that time. So I want to, right here, I'm going to introduce Dr. Van Sickle. Thank you very much.
Thanks, Dr. Steele. It was nice to see him in all the PESTOLA website and everything, because it actually ties into why I'm here, because Joel was my mentor with the first HPP patient about 3 or 4 weeks into my fellowship. So I think it was the second patient ever that had been at Vanderbilt that they made the diagnosis. And I don't want to go too long since I don't want to keep the presentation and run over for the afternoon. But he mentored me for about 1.5 years and then kind of got me on this pathway into HPP. It's a rare disease, and I usually poll the audience. Anybody make a diagnosis of hypophosphatase or manage a patient with hypophosphatase? We have at least a handful. It is a rare disease. I currently have 6 patients, and over the years I've had 8, not including the Vanderbilt patients. So if you have them, it's kind of like some of the obesity things. There are probably some maybe in your practice or in your institution and various other clinics. But hopefully today you'll find this useful presentation. I will skip through some of the cases that are adult focused and kind of hit the highlights clinically for what you would want to either know about your patients as being pediatricians, or potentially questions you could also ask their parents that might be relevant in making a diagnosis of HPP. So there'll be a series of cases that we'll kind of briefly discuss. This is a 21-year-old woman who was referred to a rheumatologist by her primary care doctor for some pain, ankle pain and fatigue. Busy slide, but essentially for about 6 months she had some chronic pain in her joints, and particularly her one ankle, really with much swelling or any redness, but just definitely had some pain. It was getting worse. She'd had history of some stress fractures when she was in her teen years. Social history, pretty unremarkable. Family history, she had a mother with fibromyalgia, and she takes some ibuprofen for the pain. It works reasonably well for the pain when she needs it. And denied any kind of really negative view of symptoms. So she sees the endocrinologist, rheumatologist has a fairly benign exam, other than her ankle's tender to palpation, but there was no swelling or redness or warmth. Got some baseline blood work, which is pretty much only notable for the alkaline phosphatase, the ALP, which is flagged as low, and the calcium is a little bit high, especially for an adult. They did an X-ray of the ankle, which showed a little bit of chondrocalcinosis and then some osteomalacia. But basically, we come to, when you look at ankle pain, and this is an adult patient, you can have a fairly broad differential diagnosis. And one of the important things is, how do you start narrowing that down? Well, through the medical history, you can already probably rule out things like Lyme disease, by travel history. On her physical exam, most of the inflammatory type things, would be a little less likely. As well, she doesn't appear to have, other more common adult features of ankle pain or swelling. Now we have some imaging results, which may limit a few more things, and then we have lab results, which would eliminate a few other things. But the key thing to point out is, do we have any information that was already there that may not have been noted, may not have got anybody's attention, that can help make that definition of the diagnosis? And the key thing out of today's presentation, if you aren't even familiar with HPP, and I can tell you one cool thing from having that patient with Dr. Steelman in the first few months, it was actually on the in-service exam, and I got questions right, because otherwise I probably wouldn't have had any idea. So it does show up on boards if you're fellows, but it's one of those things that low ALP is the biochemical hallmark of hypophosphatemia. Consistently low ALP on multiple occasions. The thing that was overlooked in this case, and to be honest with you, it's not the first case, and this is a hypothetical case, but it's not the first case where I've heard of some labs being not necessarily noticed when you talk adult patients who have been later diagnosed in adulthood by other doctors, and found that in their old history, looking back, that they've had cases where they've had diagnosed ALP in their childhood. It just the diagnosis wasn't made. So they did some other additional testing, had a DEXA, they had some low bone density, so got prescribed a bisphosphonate bisphosphonate, and then was going to follow up with PCP for ongoing care. The key to this is with signs and symptoms on a low ALP, you should entertain the diagnosis of hypophosphatasia. So what is HPP? It's a progressive systemic and metabolic disorder. It's caused by loss of function mutations in the ALPL gene. This leads to deficient tissue non-specific alkaline phosphatase activity, and this is the biochemical hallmark of HPP. And why that's important to remember is that you'll see as we go through these other cases, the symptomatic presentation can vary from based on other factors. It's not a pure members with the same gene mutations can express various symptoms differently at different points in their life. So it's important to be on the lookout for that low alkaline phosphatase activity. And why this matters is because it disrupts normal bone mineralization. We'll see that in the next couple of slides, and it also alters the calcium phosphate homeostasis. Now, because it's going on throughout life, that's one of the reasons we talk about being progressive, that you can often see of manifestations as they move through childhood into adolescence and into adulthood. In this disrupted bone mineralization may result in things like fractures, but also just normal bone mineralization and the normal activity that kids especially have to undertake, and the stress that they put on their bones, even if they're not fracturing their bones, can often have significant impact negatively on their development, and then further on in their life have other consequences potentially throughout their entire life. So just a brief slight biochemistry of how it works is that the main role for alkaline phosphatase is it's an extracellular enzyme that's attached to the surface of the matrix vesicle in mineralizing bone. And its job is to basically cleave pyrophosphate into single phosphate, so it's able to bind with calcium and help the growing hydroxyapatite crystal at the zone of mineralization in bone. So in healthy bone, you need this alkaline phosphatase activity to split the pyrophosphate. Well, what happens in HPP, you have low alkaline phosphatase enzyme activity. So you're not only not cleaving that pyrophosphate and incorporating it into growing hydroxyapatite crystals, but also the pyrophosphate itself serves as an inhibitor of the enzyme. So not only do you have low activity that's not allowing bone to mineralize appropriately, but one of the buildup products of it can actually feed back and inhibit the enzyme activity that is still available. Now, this leads to accumulation of poor bone quality, and then also you'll see when we go into some of the other symptoms can lead to other multi-systemic consequences. And so classically, people think of it as a bone disease, but it's not the only way to think about it. And particularly in pediatric cases, mental manifestations are key. Almost all the patients currently all had early tooth loss within the first probably age 2 to 4. They had early tooth loss. The first patient we had in my current practice, his teeth. He's the only teenager that I ever met that had partial dentures. So not hard to think about that if you know about HPP, but that's not the most common thing. You see patients in your practice all the time with diabetes and thyroid, and how many are walking around with partial dentures in their teen years. So dental manifestations, early tooth loss, poor dentition, periodontal disease is one of the key things, especially in pediatrics. Rickets and osteomalacia, bowing of the legs can be more common, some short stature. Fractures, in my personal experience, I have not seen that in my pediatric population all that much. Most are through dental manifestations. Again, this is the expressivity of the disease, but I have not had patients fracturing. The only fracture that I've had is in the one who started, he's on treatment for his disease, and he started becoming more active and led to a fracture because he started doing some really silly things that he probably shouldn't have been doing. So skeletal manifestations and fractures is definitely something though to keep in mind as a definite cause to go down the path towards hypophosphatasia. Muscular weakness and pain is a very common, and also bone pain are very common complaints of the pediatric population. And then you can also, because of the buildup of calcium and having to treat that extra calcium that's not being deposited in the bones, it can have nephrocalcinosis and renal damage. So the second case is more of the pediatric endocrinologist route. So this is just a 7-year-old girl who's referred for short stature, also some fatigue. She's always been small, like a lot of the kids we see, steady along the 2nd to 3rd percentile. Normal growth velocity, she's just always been small. She's had about 3-month history of fatigue. She just got over a strep infection about a month ago. So new onset, but also had been ill in that time. Pretty unremarkable history other than she had early tooth loss at 3 years of age. Slight delay in meeting some of her milestones, walked a little bit later than normal. Otherwise, health-wise, has been a pretty healthy child, not on medications. Parents are on the smaller side. She has a little bit of bowed legs on her exam. Now, these, because I'm speaking to pediatric endocrinology crowd, these were labs that were obtained by the primary care doctor and sent to you because they were trying to help you out. They know the wait time to get new to is so long. They went ahead and did some growth screening labs for you. And so they did some labs and they sent them in. I say that because nobody does a growth hormone on randomly, just keeping that in terms of pediatric endocrinology we're both speaking to. So basic lab work, nothing really that remarkable. Actually, nothing flags abnormal. So she gets seen by the endocrinologist. Doesn't really notice anything with a normal growth velocity. Says, "Hey, I'll just keep an eye on you. We'll follow you for a little while, and if you have any slowing down in your growth velocity, consider some further evaluation." And he did, by the way, or he or she did check an IGF-1, and it was -1 SD, so it wasn't super low, but it was at least in the range of normal. So again, endocrinology, it's not flagged as low on the lab report that they received from that outside hospital lab. And so as they're just going to kind of follow it over time. But the key signs and symptoms could be there, and the low ALP, which we'll talk about later, is there. So you could make a diagnosis of HPP. Now, one of the things are that ALP levels fluctuate during childhood. I know we're all pediatric endocrinologists and are used to levels that change over time. But this is a graph that puts together that we know alkaline phosphatase activity peaks during the growth spurt in adolescence, decreases into adult levels, and also that we know bone mass accrues into our really mid to late 20s and then will decrease as they move through adulthood. But one of the things that from some studies that have been done in the past in this left-sided panel in HPP is that this is the average ALP values from natural history studies. Their levels are consistently lower than the normal range in females with females who have average ALP, normal levels of ALP. And then in a study that looked at some genetic conditions that have low bone density, including HPP, you could also see that a peak bone mass accrual was actually less. So having low ALP activity, could that lead to low bone mass accrual or bone mass accrual throughout the lifespan and then lead to problems later on in life? Definitely. And this is a slide that is done from, again, several natural history studies in HPP that have done different age groups. And you can see that fracture rates do go up as you get older. So infants and young children, about a quarter have had fractures, and those that are under age 5. When you get to between 5 and 15 years, you're up to about a third of them have had fractures in these particular studies. But when you get to adults over 18, 86% of a fracture. So definitely it can be something that doesn't always manifest in childhood, but that because of the progressive nature, it's a lifelong disease that leads to disease in adulthood. In the final case, this is a 42-year-old woman having difficulty keeping up with her daughters. She's very busy working. She's had a long history of bone disease from when she was younger. She has to use a cane to get around, and she has to really cut back on her physical activity because she just can't tolerate going all the time. Low bone density for age in her past medical history. She did have some fractures when she was younger. Past medical history in her family, there's some osteoporosis and fibromyalgia in the grandmother or in her mother, and then some hypertension. And she takes naproxen and some calcium and vitamin D supplements as she was told to because of her history of bone disease. So she's seen by the endocrinologist, who notes that in her most recent lab work, she did have an ALP of 30 in her last set of labs 3 months earlier. So when you have, and then look back in the chart, found 2 additional low ALP levels, plus with the history of fractures, low bone density for age diagnosis, and her short stature, imaging this time didn't necessarily show anything significant other than a poorly healed fracture, and the MRI X-ray was inconclusive. But there's enough history there that you should be able to think about the diagnosis of HPP. And I think the most important thing is to just, it's a rare disease. I mean, people, the estimates of 1 in 100,000 back when I was in fellowship and looking up the paperwork on the papers around it, it's probably adjusted a little bit more because we're more aware of it in the last 10 to 15 years. But it's still a rare disease. You may have some in your practice, you may not. They may be in the rheumatologist's office down the hall from you. But because if you hopefully get anything today, is at least understand that it's out there, and if you can catch it, catch it. And so in this particular case, the low ALP activity and endocrinologist diagnosis with HPP, and then we talked about having her daughters assessed. Now, I'm not going to get too much into genetics, but I think it's important to remember once you make a diagnosis, start paying attention to the pedigree of the family. You may have other people that would want to get tested, HPP is a single genetic disease, gene disease, but it has a very interesting inheritance pattern. It can be autosomal recessive for the more severe cases, typically the perinatal and infantile. It can be autosomal dominant, but also, as I said, the expressivity of it within a family with the same mutation is fairly diverse. But definitely, once you've made a diagnosis, you also have to start thinking about and maybe focusing other questions into other family members, immediate relatives that may also potentially have HPP. And so the signs and symptoms of HPP, like I said, they can short stature in kids, unusual gait, muscle weakness and fatigue, muscle and joint pain. That's, I would say, the most common reason I've found kids is the dental loss, and then they develop muscle and bone pain over time. And then they can also have skeletal deformities and fractures. If you have any of those features, together with low age adjusted, sex adjusted ALP, you should be able to make a clinical diagnosis of HPP. Now, this is a slide that we've been talking about over the last few years, and I think all of us who get any community referrals and our doctors who send them to their local hospital and they get a CMP and their alk phos comes back, it's normal. Well, adult levels go down quite far. You can see the 40 is often the low end, and 40 is the is the low end and normal for adults. So oftentimes, if you take that 7-year-old girl who had an ALP of 55, while in the adult lab it flags as normal, if you take it back to the appropriate age and gender adjusted level, she's clearly has a low ALP activity. So I think it's important that we just remember, that as speaking of pediatricians, I don't think I need to beat that home to anybody, because we always have to think about things in terms of age and gender. But that's one of the things that I think is most important. So just remember, low ALP activities should always raise a suspicion of HPP. Partly because you want to make a correct diagnosis. Also, because misdiagnosis could potentially have some adverse events on an individual. So if they're diagnosed with osteoporosis or osteopenia and bisphosphonates to use, those can actually worsen the hypomineralization of the skeleton. The other newer anabolic agents that are out there, teriparatide and osumab, really shouldn't have any, I don't know what the impact would be on HPP, but you're not treating the underlying disease. And then also, in calcium, that could exacerbate hypercalcemia and lead to potentially hypercalciuria and renal injury from that same excretion. But just additional things that you could do when you're looking at diagnosing and also management after diagnosis of HPP, because it's an enzyme that breaks pyrophosphate down, it does have roles in other systems in the body. One of the metabolites that can build up can be vitamin B6. It's helpful if it's elevated, but I found it a lot of times it's borderline, or sometimes it's a little elevated, sometimes it's normal, sometimes it's always normal. So it's not always the most reliable. Phosphoethanolamine is a urine organic acid you can get in most urine organic assays. Ours will do it if you send it to Mayo. I think it's but it's a metabolite that would build up as well as a secondary metabolite if you're not sure about your clinical diagnosis. If they've had any x-rays, could be helpful to look for classic features of tongues of lucency in some of the joints. Also, if they have any ectopic calcifications, you would want to monitor those. Genetic testing is an interesting one. When I first was into around this, I always thought, well, I'm a clinician, I don't need genetic testing. I should be able to make the diagnosis on the symptoms and the low ALP. But I kind of like having the gene now. I don't mind sending it because I kind of like to know for sure that they have it. Now, we do, with the caveat being that it's still only 5 to 10% are probably not detectable because of intronic mutations that affect other aspects of the gene and the way it's expressed. But it always makes me feel better if I have a gene that's known and I can detect the mutation. But it doesn't mean they couldn't have as well. Then, just as part of when your management, physical therapy is very important, plays a role in that, especially for growing kids and helping them keep up with their developmental skills so they don't fall behind. But it's definitely a comprehensive disease, and you may have to involve other individuals in the treatment team beyond just the endocrinologist. So I'm going to go through this one pretty quickly because it's kind of like the tricky thing that people like to put in the presentation. This is basically, we talked about these people all had various symptoms that are consistent with HPP. They all had low ALP. So you should be able to make the diagnosis of HPP, but the fun thing is it's the same patient, just at different ages. If you take that 7-year-old child and look at her again when she was 21 and going to college, and then as 42 as a mom of 2 kids, the symptoms were there throughout the lifespan. ALP was low throughout the lifespan. That diagnosis can be made. So we talked, it's progressive systemic inherited metabolic disorder. It's the ALP gene leading to low ALP enzyme activity. And that's the key hallmark of hypophosphatasia. that disrupts bone mineralization and calcium homeostasis. That can lead to significant problems throughout the lifespan. And that those expressive of those consequences can be different at different ages. So diagnosis of HPP, if they have keystones and a low ALP, is you should be able to make that clinical diagnosis, or at least have it high enough up on your list that you can then say, do I need to get genetics, or do I want to look for other confirmatory metabolites to make me feel sure that I have that diagnosis? It's just important, again, not to down it again for the pediatric group, but using those correct age and sex adjusted ALP reference levels. Now, there's a couple quick slides on infants. We've been around in infants, so I haven't had an infant since. All my kids are adolescents or childhood cases, so I haven't had an infant since. But it's just important to realize that mortality in infants with HPP was very high, nearly 75% by 4 years, mainly because of hypoventilation. They have underdeveloped lungs, lung hypoplasia, because you can see the bones are very thin, they're underdeveloped. This child already has an ET tube in, and you can see that used to be the problem. They used to require mechanical ventilation, and if you required mechanical ventilation or some type of invasive ventilation, you essentially your likelihood of dying was nearly 100% by that point. So fortunately, we've come a long way in that. That's not necessarily the case anymore. That's not necessarily the goal of this talk. This is more to just inform you about the disease, but there are ways of helping with the disease nowadays. So key signs and symptoms, those are the keys. Having the way to be able to make a diagnosis. And these kids will have the bony mineralization problems, like you saw in the X-ray. Up to a quarter can have seizures. There'll be 6 responsive seizures, and that's another key feature. But really trying to avoid the respiratory failure as much as possible is key. And because of their growing bones in the skull, craniosynostosis is something you also have to consider if you have an infantile patient that you've diagnosed, that if they don't have normal skull growth, they can have craniosynostosis. And failure to thrive is very common in infants as well. So just to kind of wrap up the infants, and this is, I think, the last slide. The main thing that's different with them is they'll have much more severe respiratory disease from the very beginning. Also can have seizures, both got higher risk for mortality. And so making a diagnosis is key so that you can intervene and hopefully prevent that progression of the disease that happens in infancy that leads to their early demise. So thank you. If there's any questions, I'll be happy to take any. We're almost done. So the question was, what's the lowest in the range for the age? Well, that's the hard part about that is it changes. So that's where knowing your preference. So I know our lab, they recently changed our IGF-1 level, which was annoying because they got rid of all the age ones and just went to pubertal status, which is great. But a 7-year-old pubertal child is different than a 10-year-old boy who's prepubertal. So I don't know what to do with that yet. I haven't figured out how to come up with an answer to that one. But this one is, it's really important to just know if you get a range that only says 40 to 150, you know you're using an adult range. There's a kid coming outside that. Otherwise, if you're at a pediatric institution, I would expect, or you might want to contact the lab director, they should have pediatric ranges available for that. If you're in a pediatric institution, the lab should be able to get those. As far as I know. Now there's some debate on some machines. Some companies develop their own standards versus like the ones that are listed here, the ones were done into the Caliber study in Canada, where they actually looked at thousands of kids and came up with true national normative values for age and gender, and even included ethnic groups to try to be as appropriate as possible. But it does change. I would say anything, and this is just my ballpark, if you're under about 70 or 80 at any point in life, in an adolescent or a child, you're going to be on the lower side. Go ahead.
I was going to ask you, what about pitfalls? So things that can artificially depress the ALP.
Yeah, so certain medications, glucocorticoids, fibrates, which really is an issue. Oh, so anything that will artificially lower alkaline phosphatase activity in a lab. So medications-wise, glucocorticoids, fibrates, which you shouldn't have to worry about too much. Although nowadays, in the world of lipid metabolism in kids, who knows? You may have some kids on fibrates. Chemotherapy medication, so you might get a consult for somebody who's on chemo or something like that, and maybe they had a fracture. That's hard because chemotherapy will affect that. Disease-wise, it's pretty much a lot of things that lead to malnutrition. So if they have anorexia, celiac disease, magnesium or zinc deficiency, because those are cofactors for the enzyme, profound anemia, hypothyroidism in the world of endocrinology. So hypothyroidism will do that. It's also, and then lab collection. we've all been there. Sometimes you get a specimen, you're like, that's all messed up, and it's had to be the lab that did it, so you're repeating, it's fine. Lab collection, if it's in the wrong kind of tube, because the activity, the way it's collected, it has to be collected in the correct kind of tube. But then also, remember, certain conditions will raise your alkaline phos activity. So if you're seeing a kid 2 weeks after he broke his leg, he may have higher level of alkaline phosphatase activity because he's having bone turnover through healing. So that could push him up maybe enough to get him into the normal range. Pregnancy will do that. Hopefully your teenage girls aren't getting pregnant to making them miss the diagnosis of HPP, but that's always a possibility as well. I think, let's see, I'm trying to remember the ones on that one. That's pregnancy. Oh, and then liver disease. So if they had some underlying liver disease that could artificially bring their alkaline phosphatase activity into normal, that's pretty more of an adult problem. I don't think we see too many liver diseases in our kids necessarily where we'd be stumped by it. But those are all things that can either confound to the low side or potentially to the high side as well. So it's about 1 in 100,000 was the last. I haven't seen anybody update any data on that. I haven't looked at them or seen in the last year if there's a new review or something. But now that people are out looking for it because it's been a more in the news disease just over the last. I mean, when we were there, I used to carry around like the 10 papers on HPP in my bag. I mean, I had all 10 papers with me everywhere I went because we were making stuff up as we went. I mean, we were trying whatever we could to try to help the baby at the time. But there's a lot more that's come out in the last decade with people doing natural history studies and just genetics has gotten better and looking for cases and things like that. But the best estimate I think is it's still in the rare to ultra rare category, so maybe 1 in 1,000 if we're picking up. If we're picking up everybody, it could be more common than that because, like I said, we may be picking up more people through testing than we've ever had before. But that's an old number from a little ways back.